So this is an X-ray of a 50-year-old female having the right posterior heel pain, having the Haglund deformity, calcified retrocalcaneal bursitis, and a lot of insertional Achilles tendinosis. And the MRI was done to know the quality of the tendon, and it was relatively good, but there was a lot of tendinosis around the insertional region. So this patient has tried everything, but now not responding to the conservative line of management, and now she's a candidate for the surgery. So we have planned the repair of the Achilles tendinosis, removal of the bursa, removal of the Haglund deformity. So we are taking a posterior midline approach with the patient in the prone position under the spinal anesthesia with the tourniquet on the 280 millimeters of the mercury pressure. Look at the thickness of the flap. So the flap is quite significantly thickened and it contains the subcutaneous tissue of the uh, of the flap as well, and the incision is exactly up to the tendon. So it your flap should include the subcutaneous fat, it should include the skin, it should include the paratendon of the Achilles tendon as well. And then you uh, demarcate the Achilles tendinosis, the attachment of the Achilles. Now look at here, the 50 number knife is running over the subcutaneous tissue to make the flap thickness, and a very gentle retraction. Use the forceps, but the use should be very minimized. Don't use the sharp objects. And see, I am using the home hand retractor to retract my soft tissue that contains a lot of fat, thick tissue on both the side, medial and lateral side at the attachment of the Achilles tendon. And now I am splitting the tendon into two half at the center. I am splitting the tendon into two half. So my one half medial most and the lateral most part will now retract and show me the bursa and the Haglund deformity. And now I'm exposing my Achilles tendon from the bone to get the exposure of Haglund deformity, to get the exposure of bursa, but I'm keeping the anterior attachment of the Achilles tendon as much as possible. So rather than completely detaching the tendon, I am keeping some attachment of the Achilles, because if there are some attachment of the Achilles to the bone, it helps in the early union of the tendon, it helps in the early rehabilitation, and the strength of the fixation remain good. So this is the insertional Achilles tendinosis, which I am going to remove from both the side of the tendon. We need to split the tendon a little more because we need to see the bursa. And now you can see that the bursa is visible exactly anterior. Now I am putting Alice to hold the bursa. And the bursa contains the Kaggle fat also because of the chronic inflammation happening since many months, many years. The Kaggle fat they get incorporate in the bursa and sometimes it becomes calcified as well. So this is a complete excision of a bursa. Look at here. This is a disease pathology. And most of the time it has been assumed that this is the first process of the inflammation over there. Again, a gentle retraction should continue. So look at here, we have removed the bursa, we have started removing the Achilles tendinosis, and this is the exposure of the tendon from underlying bone. Again, a home and retractor to separate the Haglund deformity from the overlying tissue. Separation of the bone from the tissue so that now you can remove the excess growth of the bone, which is called Haglund deformity. So on both the side, medial, lateral, posterior, you need to expose the Haglund deformity so that we can excise it completely, and this is also a cause of pain. So in generally in these cases, it has been assumed that uh, the source of pain could be bursa or it could be the Haglund deformity impinging the tendon. Protect your tendon with wet gauze, and then I use a mini saw to take out my Haglund deformity. Many times we get a question that how much amount of the bone you should remove. So in the preoperative X-ray, you need to plan that where is my Haglund deformity, and while preparing, your cut should be oblique. It should not be posterior to anterior straight cut. Otherwise, you will injure the subtalar joint. So this is oblique cut. So you need to identify how much amount of the bone I have to remove by taking a decision on the preoperative X-ray. And it is basically a junction of sclerotic bone and cancellous bone, which helps to decide that this is my area of osteotomy. So this procedure is called the excision of the Haglund deformity. So you have to excise from posterior to anterior in the oblique way. And while cutting the bone, you will have a feeling that I am going to cut a sclerotic bone or a cancellous bone. Make sure that your excision should be complete and you should get the cancellous bone. So a osteotome and a hammer is used to remove the bone. And now see, after removing the Haglund deformity, you have a cancellous surface now. See the cancellous surface. Now to take out this bump with the help of Ronger or nibbler, and few remnants on the anterior aspect close to the subtalar joint has to be removed with the reamer, with the nibbler. And then you have to mark the medial and the lateral extension of the Haglund deformity. This is very important because most of the time the people remove the bone from posterior to anterior considering that this is the enlargement of the bone which is causing the tendon problem. But medial to lateral excision of the bone is also very important. Still, there are some residual Haglund deformity, so I am removing it from posterior to anterior because the sclerotic bone was not completely removed. So second cut to remove the excess of the Haglund deformity. Again the same, take a osteotome, nibbler. So till you get a good cancellous surface of the bone, you should remove the Haglund deformity. Now see, I'm getting better exposure to the medial and the lateral Haglund deformity, and now this is how you need to take out the medial and the lateral by using the mini saw, pencil saw. So this is how you remove along the medial border and along the lateral border. Don't take out too much bone because you need to put anchors. So you need a good size of the bone. Don't make too much shortening, but just 2 mm of the bone on both the side. The medial and the lateral side should be removed. And then with the help of nibbler, you remove the Haglund deformity. This is the some part of the insertional Achilles tendinosis. And this is the decompression of the lateral part of the the Haglund deformity. So now you can see there is a significant decompression of the bone, significant removal of all the excess bone. Now, few fibrotic tendinosis part close to the insertion has to be removed to make the bed raw. And because if your bed making is perfect, the healing between the tendon and the bone will be better. And then you have to mark, the two holes. So I'm using a marker, one medial, one lateral, exactly at the center, at the footprint of the attachment of the Achilles. And this is the entry for the anchors, 4.75 mm. So we will use the two anchors and the fiber wire and the fiber tape. So we are just taking an entry. So these are the entry for, and this is the anchor. It's a civil lock anchor with a titanium tip, and that contains the hole for fiber tape and a titanium tip anchor lock, so that when you push, it will lock, the titanium tip will lock the fiber tape into the bone, and on the top of that, you have a civil lock option. So pass a 2 mm fiber tape uh, through the tip. So this is a 4.7 mm civil lock anchor, and one anchor is inserted medially and one anchor is inserted laterally. Here the two anchors are inserted to secure the fiber tape into the bone. Similarly, the other another anchor is inserted into the same fashion. Make sure both the anchors should go from posterior superior to anterior inferior in the oblique direction, so that you will have more bone for the purchase. And the same technique. So now we have two anchors fixed into the bone at the footprints with four fiber tapes, sorry. So you can see here two anchors securing fiber tape. And now I'm taking an entry into the medial half of the tendon and the lateral half of the tendon to pass the fiber tape into the insertional Achilles region. So a single entry, so we use a bit pin, a single entry across the insertion of medial and the lateral half. So Both the fiber tape are now passed through the Achilles insertion, and they were pulled in such a way with the with the heel in with the ankle in 10 degree of plantar flexion, so that you should have a good apposition to the bone. And now see, uh, we are going to expose the inferior part of the calcaneum, because we need to reattach this fiber tape into the inferior part of the calcaneum to secure both the ends in the knotless fashion. Similarly, the two holes on the posterior-inferior surface of the calcaneum close to the insertion, and the same 4.7 mm knotless anchor will be used to secure these fiber tapes. Again, a oblique direction, because it will give you the good purchase. So two anchors containing the fiber tape and the two anchors in the knotless fashion. So now one fiber wire of one side and the one fiber wire of the opposite side has been used to fix the Achilles into the bone with the ankle in 10 degree of plantar flexion, and that gives a knotless anchoring of the Achilles back to the calcaneum. Same, take out one fiber wire from one side and another fiber wire from the other side, and then you repair in the knotless fashion. So two anchors similar 4.75 had been used to secure the fiber tape into the calcaneum, and then you have to civil lock the repair, so you will not get any knot on the repair, and it's a minimal use of the foreign body inside the tendon. So a lot of the infection around the Achilles tendon, they happens because of lot of use of the fiber wire, fiber tape across the tendon. But with the use of this four anchor technique, you just use the very minimal foreign body inside the tendon, and the repair is super strong. So two anchors for the fiber tape and two anchor for the knotless repair. So this is how the surgery is done. The Achilles is reattached to the tendon, is reattached to the bone, and the excess fiber tape has to be cut from the anchor side, so that you will have no knots and very minimal foreign body inside the tendon. So look at this final repair. So this is crisscross repair. Look at the on table stability of the tendon. The Thomas is negative and the attachment is good. and the good repair. So you look at here, the Thomas test is negative, and you'll get a good healing uh, of the tendon to the bone. And in the last, you repair the paratendon. So in the last procedure, you just repair the paratendon and take a the vicryl stitch uh, through the tendon and just repair the cut end and the paratendon over it. And after that, you take a subcutaneous and a skin suture in two layers.